Melissa Hogg, robotik cerrahi konusunda çok deneyimli ve Avrupa'daki biraz önce Mark'ın bahsettiği örnek eğitim sistemini kuran ve Avrupa minimal invazif pankreas çalışmasına çok ışık tutan, çok önemli, bu konuda söz sahibi ve çok iyi bir eğitimci. Şu an hazır, gece saatlerinde, şu an Chicago'dan bağlanıyor bize. Onu yormamak için hemen bağlanacağım. Hi Melissa.
Hey, good morning. Well, I guess it's afternoon there. It's about 4 in the morning.
I know. Sorry,
So,
sorry. And you can start. Thank you.
okay, no problem. So, being at the tail end of those four speakers, I don't want to bore you too much. So I anticipated what a lot of them would put on there. So I'm going to just keep mine kind of light and breezy and talk about why robotic surgery is preferred. I do teach training courses for Intuitive and have money to my institution with a training robot and instruments. So I'm just going to ask some basic questions in terms of this topic is, robot being preferred, but let's talk about what is available, what is the data, however this will be light because you just had about an hour worth of that data, and then what is my experience. So in terms of what is available, and Dr. Hackert alluded to this, is that robotics is big business. Right now, the market's about $4.3 billion worldwide. And looking at the US market itself, just about $1.6 billion and growing every year. And then you could see the same growth pattern projected in the global market. But robotic surgery is not universally available, even though it's big business and even though it's growing. And this study is about 10 years old. I couldn't find a newer one, but this is just looking at the penetrance of intuitive Da Vinci robots across the globe. And here at this time, about a decade ago, over 1,000 units in USA, but you could see just in other countries like Turkey for here, 9 units. And now most likely all these numbers have gone up dramatically. However, probably the scale and proportion of numbers is still relatively stable across the world, and just a great disparity in terms of penetrance of robotics worldwide. And what are some barriers internationally? And this is a study looking specifically at low and middle income countries where robotic surgery has a high cost of implementation, a lack of trained personnel, inaccessible to disadvantaged communities, and a poor network connection. So really, even if it's preferred, there's a lot of obstacles to get it to be, a universal player in the market. And even those systems are going up each year, and green represents the most recent year. And you could see just kind of purple at the beginning. So just really over time, more of an explosion in the US as well as in Europe. But there's barriers locally. And so one local barrier is limited block time. A lot of people I talk to say, oh, the urologists have all the time. I can't even do that. And really, how can you start a practice even if you had all the optimal factors like volume, et cetera, if you can't even have time in the robot? And this is an email I just got this week. My current robotic time I have every Thursday and 2 Wednesdays. And, after years of trying to get every Wednesday, finally, January 1st, I'll be able to have a robot block every day on every Wednesday. And sort of why is that? And really it's because we bought more robots in the system, and really robots are a limited resource. And Intuitive has become nimble in their model, where initially it was a capital purchase of like $2 million to get the robot. And then they were saying, okay, well, you could lease it. You don't have to pay $2 million up front, but then, you just pay a certain amount per month. And now, because they want to get the robot into every hospital, they have something called an AMP program, which is also what referred to as paid for click. So this is what our hospital just did. And we got 4 new robots in the last month. And you didn't give them $1 because it's this AMP program, but every time you use it, there's a charge to that. So with this limited block, with this limited resource, you have the evolution of the company changing ways to get that robot into your hospital. but and also limited training. And here, this is the agenda of this meeting. And when I was looking to put my talk together and saw all the previous esteemed speakers and all the previous talks, I thought, okay, well, I don't want to have to give the same data. But Dr. Besselink did a great overview of sort of the issues with the training. But also, not to point out is that you have to be an eligible center. And he also discussed this as well, like a high enough volume of pancreas surgery in general that'll translate to the minimally invasive pancreas center of excellence, meaning you're able to rescue, you have the IR, you have the inpatient capabilities, et cetera, and then access to the robot equipment and adequate training. So there's a lot of barriers to get to have a robot be the preferred approach. But when it's available, it's amazing, and this is a robot Whipple doing sort of the retroperitoneal venous dissection. And just the visualization is stunning here, that you could see the clear picture so much better than even with loops open. And then you have the great instrumentation from the scissors just shown to the hook, which you could clearly see the first jejunal starting to come into play down there. And all the while you're doing this sitting down at a console with your shoes off and potentially with your cell phone nearby, not scrubbed in. And I think, I'm sure you've had rough open Whipple days where your neck hurts, your back hurts, or rough laparoscopic days where, everything kind of hurts. It's sort of a nice way to do surgery, not only from a visualization standpoint, not only from a technology standpoint, but also from an ergonomic standpoint. And this is a patient that underwent total neoadjuvant chemotherapy for pancreas cancer. And just here kind of taking the vein off where the gastroepiploic pedicle was. And then here we could start seeing coming down on the SMA above the first jejunal behind the gastroepiploic pedicle. And here starting to really move the SMV over in order to see more of that artery. Coming up here, sort of that vein of Belcher or the superior lateral pancreatico-duodenal vein, and going to take that. So once that's done, just really rolling that vessel over and skeletonizing along the SMA. And I think, seeing a procedure like that, and doing a procedure like this, it takes a long time to get there, in the sense that having the patients and the pancreas experience in general, and then also just having the time to maximize and perfect the robotic technique. So here, just getting right on that lateral wall, the SMA. And I actually love the hook for the robot. I know some people like to use the scissors, some people like to use the vessel sealer. I do think the hook mimics open surgery the closest, because to me it simulates just having the right angle in open surgery, but you have the added benefit that your left hand is a bipolar, and that also your hands are only the size of fingers, because sometimes it can be hard to get into a deep space. But the other thing with Besselink's point about the two-surgeon technique, it's so much more efficient to have that two-surgeon technique, because here you have a monopolar, a bipolar, and a ligature all working together. Where if you have to do instrument exchanges in robotic, it takes a little bit of time. Now, I don't have an attending at the bedside. That would be nice, but I do have fellows and residents that help me out and get to do that. And here you can see all the nice blood vessels. There was a replaced right off the SMA. You could see the celiac over there. In that kind of triangle view. So the visualization on the robot is stunning. And it's one of the reasons I prefer it, is I can see so much better. And I know I'm technically better robotically than I am open at this point. And part of it's because I do about 75 to 80% of my cases robotically. So what is the data? And I'm really going to be light on this because we just heard a ton of data from everyone. But just to summarize, distal pancreatectomy, the only trial robot versus open is the diploma trial, non-inferiority, equal nodes, equal recurrence, equal functional recovery, equal 2-year survival. But again, only about a quarter of the minimally invasive patients were robotic. And that's sort of mirrored with what we see in the United States, where about half of distal pancreatectomies are being done minimally invasively. And of those half, about 2/3 are being done laparoscopic and 1/3 robotically. And so also with the diploma trial, no difference in survival. And I just wrote a review of like all cancer in robotics. And sort of the punchline is there's no difference in survival in any cancers, even prostate cancer that has the most data. And that cervical cancer point that Dr. Besseling brought up is very interesting. Because one thing that's different with cervical cancer and uterine cancer is, so uterine cancer, no difference in survival, cervical cancer difference. And a lot of that is actually deemed because of a cervical manipulator that's placed onto the cancer itself to move around the uterus during the procedure. And this probably spills tumor. So I don't think it's really a technical factor that's leading into that. And only about 18% of those cases were done robotically. But there are ongoing trials now doing that without the use of a cervical manipulator. But it's always just important to kind of think of all these things through when you're changing your technique. And this is a national database study from the US, just also looking at cancer and distal pancreatectomy, not randomized. But when you do see some of these high series, there can be some data to favor the robotics. So higher lymph nodes, improved survival, higher rates of survival, higher rates of receiving adjuvant chemotherapy. And I do think this NCDB data is kind of pure because it's abstracted by a third party. It's not what by hospital administrators, not by surgeons collecting their database. But also has been talked about, there's eagerly many anticipated Whipple trials coming up, the Europa trial by Dr. Hackert, the Diploma 2 trial by Dr. Besseling, the Portal trial that should finish accruing next year, but there was another Chinese trial. It didn't have a great acronym, but a long number, but I just reviewed it recently. So I think with by this time next year, we'll have 4 randomized robot versus open studies. But without showing a lot of specific data in looking at this topic ad nauseum, in general, blood loss lower in robot, length of stay lower in robot, wound infections lower in robot, OR time longer in robot. Almost every study says that. Now, in general, perioperative morbidity and mortality are equivalent, and a few studies here and there may say, oh, robot is better in this, and then again, in general, R0 lymph node harvest survival, but the same in all studies. Every now and then you see one, robot's better in this, like the one I just showed. Now, what about robot versus laparoscopic? Pretty much universally, you see conversions lower in robotic, EBL lower in robotic. And then if it's a distal specifically study, a lot of times splenic preservation better in robotic. And in general, the same morbidity, mortality, and the cancer outcomes. So what about my experience? I think, one of the things that echoes in everybody's talks today is really monitoring your outcomes, publishing your outcomes, and being transparent about the implementation. So, Pittsburgh, showed the feasibility, showed the safety, was the first institution to do a multi-institutional study showing the efficacy, did do cost-effective studies, and Thilo Hackert showed some of this data with the ERAS and the Whipple and the robot being good in combination. There's also a study I did in distal pancreatectomy. Also patient-centered outcomes. And Dr. Besseling talked about the Diploma 2x2 trial that has Fitbits. And we did this in we had one of our studies here with these quality of life surveys, looking at right after surgery, the dramatic drop in quality of life as echoed by the blue. And then after in the hospital discharge, somewhat recovery of the quality of life, and in the robot going above the baseline, but not for the open. And then when you look at the 3-month post-op, you could see a huge recovery in the quality of life in the robot compared to the open. And then this is our data from the Fitbits, where you see the robot in red. And you can see, in general, higher steps per day over the 60 days post-op. Not only that, is it teachable, And Dr. Bestlink showed a lot of the data from our study there, but the robot training program that I developed had a simulation curriculum where you master the console, and that's been validated. An inanimate biotissue curriculum where you master the loss of haptic feedback, and that's been validated. Mastery of the procedures, which is essentially unedited library. Master of the psychomotor performance, which is essentially a coaching curriculum for fellows and a proctorship curriculum abroad, and then decision-making and judgment. And then this actually shows the looking at second and third generation learning curves where the outcomes continue to improve as you train new generations of surgeons. And then also it's transplantable. If this data had died in Pittsburgh, we wouldn't be here today. But the fact that so many others have picked up the torch and run with it so far, like the Dutch, is pretty amazing. And so with this evolution, we always think about the learning curve, but now we're really beyond the learning curve in the sense that, I published on our second and third generation learning curves. And, what could that potentially mean now? I'm about 10 years in practice, have probably done about 300 distal pancreatectomies. And I've only had 2 conversions of distal pancreatectomies, and I've only done 3 distals even open in my career. And 2 of them were tumors over 20 centimeters, and one was because the patient was undergoing an open partial nephrectomy anyway when I did a distal. But I think that, what I mean to say is that this isn't a cherry picking of cases. This is doing essentially every case distal pancreatectomy, because that's the way I was trained. When I was a fellow at Pittsburgh, they were already doing robotic distals. So when I was a resident at Northwestern, I remember doing like 3 lap distals, and all of them were converted to open, and it was a big, to do them, et cetera. And so I think that I could already see the difference between the lap approach and the robot approach just in my training. And then when I became an attending, it just never even occurred to do anything other than robotic or minimally invasive. And in fact, when we were just first approached to join the diploma trial, Mike Kendrick, myself, Herb Zay, et cetera, we just didn't have equipoise about open versus robotic and didn't want to randomize. And here you see a case, and this is the SMA right at the bottom of the screen. And this is antegrade Rams procedure for a bad cancer, which has been not only given chemotherapy, but also radiated. And you can kind of tell by the fibrotic tissue planes and the edema that you see a lot after the radiation. But I think, the robot gives you this nice, calm, leisurely approach to a difficult case. And not only that, but now I almost think we're on the 4th generation. I always say, like, the 1st generation was sort of Herb Zay and his predecessors like Pierre Giulianati, that Dr. Zerkat and myself were like the 2nd generation, because we learned from people hands-on that had already done this. We weren't like going through the dark on our own. Where do we put the ports? How do we do stuff? And develop the training program. The 3rd generation, kind of our fellows and the other people who trained after us. And now with the robotic penetrance so globally, as I mentioned earlier, people are learning it at a different age. It's not, 40, 50-year-old surgeons now saying, what's the robot? Where are all the buttons? We have interns coming in first year, second year, getting on the robots to do inguinal hernias. So this is a study I did over the last few years with the University of Chicago residents, where we have a 2-week curriculum for PGY3 residents where they only do robotic simulation and training. And then what we saw was that the OSAT's performance was better in robotic compared to doing these same drills laparoscopically. And also we gave them a bunch of, NASA task demand, et cetera. And the physical and mental demand of the robot was a lot less than laparoscopic. But then furthermore, when we asked their preference in terms of technique and ergonomics, everything favored laparoscopic worse for ergonomics, laparoscopic worse for technique. And this was for both the HJ and GJ. So the basic questions: what is available? you know, the penetrance of robotics expanding, but it's not universal. We have to remember that in terms of preference. What is the data? There's advantages, but there's a learning curve, and that has to be respected because it could be dangerous to patients. What is my experience? You have to monitor outcomes, you have to be transparent, and you have to undergo training. And so in conclusion, that review I was telling you I just did in terms of looking at cancer, and this is United States data. So robotic prostatectomy, 90% are being done robotically. Robotic thyroidectomy, 0.3% are being done that way. And you could see across the board. So hysterectomy, 57, rectal, 28%, gastrectomy, 17%, esophagectal, 13%. So very impressive in the Netherlands, 25% being done robotic, but still in the United States, only about 7% of robotic Whipples are being done robotic. However, about 20% of distals are being done robotic, I would say. So in conclusion, we have to kind of worry about the penetrance when we're thinking about the preference. Thank you.
Thank you, Melissa. It is a fantastic speech. So it is too late for you. Just maybe we can accept one question from audience.
Sure.
Herhangi bir soru var mı? So, yeah.
Hi, Professor. It's always a pleasure to listen to your robotic experience. I just want to ask you, as an expert in robotic surgery, what will be the soonest next step in the robotic technology that you would expect to have as soon as possible?
Expect to have as soon as possible. It's interesting because nothing's happening fast enough for me in terms of competition, right? You know, I think that if there were more competition, there's the Hugo robot out there. I don't think the instrumentation is quite where it needs to be to do a robotic Whipple. I was in Italy earlier in the year and saw some gastric bypass and some other colon cases being done that way. And I think that's very intriguing, and having 4 different units come together instead of one. I do somehow see in the future, just like we have booms in our ORs with you know, the suction, with the monitors, with you know, the light course, etc. You know, I would hope to vision one day where you kind of just have, like, you could pull like a robot boom down where it just grabs your camera, holds that, grabs a retractor, holds that. If you have a couple more sophisticated instruments where you're sitting back on the side. I know Ethicon, you know, is coming close to their robot on the market, but still, there's a lot of closed lips. You have to only see it on site and have to sign a non-disclosure before you could even go into the room. So I think that there is evolution, there is competition, but I think it's not ASAP. And the other thing is, I do probably think we're on the 4th generation robot with XI. I do think we're within a 1 to 2 years of the next 5th generation in terms of intuitive, and I'm not sure what that looks like yet, but I do think that's probably I think probably the next robot after Hugo will probably be the 5th generation intuitive.
Thank you very much. And the last question: what do you think the impact of robot in our surgical life regarding the role of women surgeons? Because I have met in the last robotic surgeries summit, Leila Rashidi. She presented that she's performing outpatient robotic colon resections. What is your perspective on robotic surgery and women surgeons?
I've never thought about that. I know her work. It's pretty amazing, especially with the same day discharge. And we have a colorectal female surgeon at my institution that's trying to emulate that. I think that the advancement in women in surgery and the advancement in robotic surgery are happening in parallel, and probably not that much overlap. But I will say, just like drilling it down on the robot and not the female, that when I was just started my practice, no one even like cared or knew about the robot from a patient perspective, and people were saying we're crazy, you shouldn't be doing that from a, you know, what's going on in the pancreas world perspective. After about 5 years, I had VA patients asking me, which a VA patient is a very like low, they're very not demanding at all. You know, they're kind of like, whatever, doc, they're not high maintenance. So to have that population start to say like, I want to have this robot, was a definite change in sort of the perspective of it from a patient perspective. And at that point, more people were adopting it at meetings, et cetera, but they were saying, I think it's great for everything but a Whipple. I would never do a Whipple that way. It's crazy. Then 5 years later, you know, everyone's like, I love it so much. I want to do Whipples that way. And then, you know, you kind of keep thinking that the robot has reached its limit. But then even when people were doing thyroid, that seemed crazy. But now inguinal hernias, something that people would never think being done robotically. And then breast surgery, really an explosion in nipple sparing breast surgery. So I just keep being amazed by all the things that they find uses for the robot to do, and how much the surgeons love the technology. And so I just think that the robot is here to stay, and it's only going to become more accessible as the companies become more nimble on how to get them into the hospital. The only thing I say is we have to have a parallel training program as we expand the penetrance, because at first do no harm is our motto as surgeons and doctors.
Melissa, thank you again, and it is honor having you and our association in behalf of our Turkish society. And I really say deeply thank you, because it is too late for you and you need sleep. I am so sorry for this.
No problem. I'm going back to bed. Take care.
Next time we are waiting for you in Antalya.
All right.
Okay.
I would love
See
to
you.
come. Bye.
See you. Thank you.